Dr. Morris is the chief from the Division of Pulmonary Critical Care and Sleep Medicine at the University of Kentucky. So we're looking forward to you sharing your experiences with the sudden influx of COVID-19 patients in your facility. Tell us all about it.
I will. Thank you. And thank you for the invitation. Thank you for the Draeger team for organizing this and for all the other panelists here. It's a bit of a unique story for a few academic medical centers. Our university has a contract with one of the U.S. federal prisons, one of the medical prisons. And there are a few in the country, they call them an FMC, Federal Medical Center. And just as by way of background, the University of Kentucky is a big regional center for that area. It's over 900 beds. Our base of operation for the medical ICU is 44 beds, but we're never just in those beds. And there's somewhere in the neighborhood of 150 or 170 beds in the institution, and we're always scattered in there. But the experience we had with an outbreak in our prison was one, as you can imagine, that someone had a very large nursing home with ill patients. To give you an idea, I think there's over 1,000 inmates there, and to be in a federal medical center, these people are the sickest of the people in federal care in the prison system. They're multiply comorbid and typically end-stage cancer therapies and organ transplant candidates or recipients. So these are a lot of very, very sick people, all gathered under one roof in very close proximity to each other. It's a sophisticated facility. They have their own nurses and their own physicians, but they are not necessarily at the point where they take care of the high-end acute illnesses there. That's why each of these places tend to have a contract with a university or an academic center nearby. They are leading in many ways since before COVID, we had many of our clinics engage in telemedicine and deliver health care to the system of inmates there through telemedicine, run by the doctors and nurses on their end and our end in our clinic. So when we had to go to telemedicine in clinics, for many of us, it wasn't necessarily brand new. But across our inpatient system, it was not uncommon to have one or two inmates at one time be inpatients, and even in our medical ICU, it wasn't uncommon. And I'll say one or two things to help preface how our experience went, that there are federal mandates, federal regulations that have to be attended to have these patients cared for outside of a prison. And one of them is that every prisoner is accompanied by 2 federal guards. So keep that in mind. And then the other thing is transportation is never communicated. And so this is also a very important point, which I'll bring up here in a minute. One of the things you learn in caring for people is you never discuss discharge date with a person. It's discussed with the prison personnel. And so transportation to and from is, for security issues, always of a high importance. But you can imagine how this might play into how triage and delivery of sick people in a short period of time might play into this. So what we experienced was, overall in Lexington proper and servicing about a 2 million patient area, a slow burn of community COVID positive patients. Compared to the coasts, it was considered minor. And the pace allowed us not to have to activate our usual series of stepwise increase in physicians and nursing. We designated one floor of our medical center that held 32 beds, 16 of which usually operate as ICU beds, but it was designed in a way for these kinds of emergencies. The 16 floor beds on that floor can run ventilators and can be shifted to an ICU. So when we were operating in March to the third week or so, we were seeing about a steady 8 or 9 ventilated COVID positive patients. And with the influx, there was an outbreak that grew very, very quickly at this prison. Our staff went from handling an average of 8 per day to 28 in a very short period of time. And so that necessitated several things about us moving to the floor and taking over ICU beds, which were usually floor beds, and running not in our usual area. So that was one thing that was different. But you make do. Also, we learned very quickly to become facile at triaging. And triaging was not the emergency room type of triage because of transport. And this is what I brought up before. Because of transport, we would get a very late notice that the ambulance, and it was more like a bus, an ambulance bus, was on its way from the facility. And it was really never communicated the degree of illness for those particular people on that transport. Now, the testing was done at the facility, so we knew that they were positive coming into our facility. We did a few right to the emergency room, and we shifted after about a week, having these patients come right to the ICU. So we were the recipients directly off the transport. So we learned to be very quick in assessing. The volume of people on the transport was somewhere between 4 and 8 per day. They would make one trip. And to give you an idea of how intense it was for a period of time, there was one late Friday where of the 4 people inbound to the ICU, 3 of whom got intubated within 30 minutes of arrival. So the pressure that put on us was not only the logistics of taking care of people with all the PPE and making sure of all these comorbid themes were attended to, but all of the ICUs, for people who are listening in, have capabilities of rapid intubations and quick movement, but we had to escalate it to how many can you do in a short period of time. And so how can you turn over your equipment, your staff, and ready your ventilators? So you might have to go from 0 to 60 miles an hour very, very quickly to support them. The other thing that became interesting in handling these things, and this is something I've heard from other facilities as well, is the frequent need for discussion. Many of these people would wind up on high flow and judging the trajectory of decline. And at each notch, either of the flow or the oxygenation, the respiratory therapists and the staff and the docs would have a conversation of documenting what's the rate of decline of this person, and having a team approach to one more notch down and we're going in to intubate approach. And that worked out very well for us. Overall, of the 60 or so folks that I think have come through, the mortality rate has been in the high 20s. That's not atypical from our usual ARDS mortality that we've been seeing across the year. So it's interesting. The other things we learned were, when we got to the point of having about 28 or 30 out of the 32 beds, doing the math, when you look down the hall with each of these patients coming with 2 federal guards, the crowd control necessary, and they were wonderful, they were working with us, but still having that many bodies and it's a newer hospital, so there's more room compared to some of our older wings. This was a newer wing. It was still quite a challenge, even when you had to transport someone to CT or some other place, that you had to rearrange all the bodies that were in the hallway. Rounds were interesting. HIPAA was interesting, but I think we got through it very well, and many people accommodated these themes. But working around 2 prison guards per patient outside the room became very challenging for many of our usual workflows. but I think you learn very quickly how to take these in stride and move through it. So crowd control was important. At one point, even dealing with the announcement of rounds so everyone could keep their voice down, because it got to the point where it was very hard to hear at some points, even with a low murmur conversation from 40 or so federal guards in the hallway. But they were very respectful of us trying to move patient room to patient room and have a serious discussion and assessment. So those were our experiences. I think the input I would say that we learned is to have deployment plans, triage plans beyond our usual. We would never see the rapidity of having to intubate this number of people in such a short time frame. We didn't know when they were going to arrive or the density coming in because of certain security themes. So you just stayed prepared and planned for the worst. And the good things that came from this was the frequency of discussions and reassessments that were necessary in someone who was in their pre-intubation phase. We had a few who went right through and never did require intubation, and they got up to a certain level of high flow and then walked back from the edge. But those who continued within, say, hours of notching up on their high flow needs, that trajectory got everyone's attention, and the planning became such where handing off even from day shift to night shift, we would be marking out the number of times the high flow had been increased with the threshold cut for this person. If this is reached, the recommendation is to go ahead with the intubation plan. So I hope everybody has those types of plans in place. I would not hope that someone has those experiences, but for folks who have nursing homes in their areas where a quick number of people might be exposed and get sick simultaneously, and assessing for those, there may be similarities in your planning as to what we went through. And at that point, I'll say thanks again to the Draeger team and to Ed for inviting me. And if there's any questions, either now or whenever you say ready to go. And thanks again.
Yes, absolutely. Put your questions in the question window. That would be great. I do have one question that's come in for you, Dr. Morris. So I'm wondering, do you have any thoughts on the perspective of putting multiple two patients on one ventilator when inundated with the numerous amount of patients that you had? Was that
Luckily,
ever a thought?
I think very, very briefly, and then with the exploring those possibilities, I say one thing that we did explore and got to at one point was having the rooms in this wing are designed, and they were very large, and the plumbing on the 16 typical ICU beds could take 2 ventilator setups, 2 beds inside the room, 2 series of monitors. And we did that once or twice just because of the need for cohorting and where things were on the floor. But no, we didn't have to get pressed for the need to consider 1 ventilator for 2 patients. The flows issues, the need for control of protection from cross-contamination, those kinds of themes from the literature and from what we could get from our respiratory therapy experts, we never felt comfortable moving in that direction if we needed to. Luckily, 2 things that in our area just came through. We work closely with a chronic ventilator hospital that had a series of ventilators in store that were on loan to us. And we work closely with a community hospital respiratory therapy school who also had the need to teach their students across a wide variety of mechanical ventilator companies and models. And so we had access to another cohort of ventilators there. So our fleet levels never were threatened, luckily, but I can imagine that's a question that comes up for many people who didn't have access to the numbers of ventilators that we did. So, but we did not have to entertain that beyond the chalkboard theoretical.
Okay, great, thank you. Another question came in. Did all of your patients with COVID-19 require supplemental oxygen?
I would say now that at the beginning, yes, because of the acuity and the triaging, very few were admitted without oxygen. What we're seeing now, many of the institutions in our region have gone to universal testing on admission, and we're seeing asymptomatic positivity. So people come in with a GI hemorrhage, I'm here for a bowel obstruction, and oh, by the way, I'm COVID positive. Clear chest x-ray, no respiratory symptoms, no oxygen needs. So that's become a challenge, keeping up with those patients' needs, and going to operating theaters and operating rooms has become with the frequency that we're seeing, it's up and up and up. So it's becoming like the universal problem now. We have to have that availability and capability everywhere in our institution.
Good, good. And one other question I have here is, do you use heated high flow nasal cannula in your treatment? And if you do, what was the maximum liter flow to prevent any sort of aerosolization or cross-contamination concerns?
Our nasal cannula was traditional. Our high flow was such where 100% and 60-liter operating. Our PPE was such with our negative pressure rooms that we could apply our high flow with a high degree of the sense that we were safe to our staff. So far, none of our staff have had a positivity themselves. So knock on wood, we've been lucky in that regard. The coordination of the care of these patients, I would say one other thing locally, and I think nationally, it has put our colleagues who are such great caregivers, our respiratory therapists, more in the spotlight. And I think more and more newspaper pieces and magazine pieces have been brought to shine light on our colleagues who have been trained as a respiratory therapist, who they were just leading the charge here, and they would be in the room as much as anybody else and would be leading our assessments and leading our delivery of these devices, and were very much a part of the decisions to move from, say, a high flow to intubate.
Right, right, very good. So a couple more questions have come in. I'm just going to continue on. We've got a few more moments. So one person writes, I hear the secretions are very different. I hear that they are sticky and a very different consistency than what we may be used to with other diagnoses. What's your thoughts?
We saw a spectrum. I would say somewhat from very dry acute lung injury to minimal scant white secretions all the way through to yellow thick secretions, but nothing that we could predict, even from knowing the comorbidities underlying if someone had severe end-stage emphysema. It wasn't something that we found, maybe because of the smaller volumes overall compared to what folks on the coasts were experiencing. I couldn't estimate for you any predictability or a routine COVID positive pattern.
Sure. Okay. And one last question before we move on. Are any of your positive patients currently that may be non-intubated patients, do you have them in any non-negative pressure rooms?
No, we were lucky enough to have sufficient working in a facility that had a recent build. The negative pressure rooms were quite multiple, and so we've not had that situation come up.
Very good. Well, again, Dr. Morris, thank you so much for joining us today.